Projected Augmented Reality. So we got a patent on it. I've been working on this for 10 years. So we could actually see temperature on the skin.
Built in a shed.
97.3% could be verified with handheld Doppler.
We are definitely looking at early adopters. People will tell you it's not a great idea. Just keep on going, just keep innovating, just trying to find new stuff.
Hello and welcome to another episode of The Rest is Plastics at JPress. Today we have a really exciting episode because it talks about innovation, but also a topic close to Anton, my co-host's heart, breast reconstruction. What's more is that this paper won the JPress Award for the most cited original research article in 2024 to 25. So the name of the paper is called Projected Augmented Reality in DIEP Flap Breast Reconstruction, projecting perforators on the skin using dynamic infrared thermography.
We spoke to the authors of the paper, Dr. Eva Meier and Dr. Stefan Hummelink. Dr. Meier is a PhD student looking at projected augmented reality for preoperative perforator mapping in free flap surgery and plastic surgery resident.
Dr. Hummelink is the senior author based at Radboud University Medical Center,
focusing on breast reconstruction and lymphedema. He's also the inventor of this system, as well as the co-founder, chief technical officer and chief medical officer of Exolumen, a startup that's bringing this innovation to operating rooms worldwide. They're plastic surgeons in Nijmegen in the Netherlands, and we had a really great conversation about this really exciting innovation. It's a really wonderful episode, and I hope you enjoy it. Okay, so Eva and Stefan, welcome to the podcast. We're here to discuss your paper on augmented reality in DIEP flap breast reconstruction. Can I ask the first question? Why did you choose to study this topic?
Well, in the reconstructive surgery, we also tend to search for new innovative techniques, right? And preoperative perforating mapping is important. And a couple of years ago, we developed Projected Augmented Reality, and we called the device the Anatomy Projector. And it projects a virtual deep flap planning based on CT scans directly on the skin, and it has been published on the JPress already. And in that planning, we highlighted perforators, veins, lymph nodes, and flap size. And we've been working on it for the last 10 years or so by now. And in the meantime, we read up about papers on thermal imaging, and it's very interesting technique. However, it required a very expensive camera system. It was quite cumbersome to set up, actually. So we wanted to make that method like user-friendly and portable. And that's why we decided to upgrade the Anatomy Projector with such a thermal module. And that actually allowed us to project temperature onto the skin in real time. So we could actually see temperature like on the skin of the patient. I thought that was pretty cool. And so we saw like the temperature for each square millimeter on the skin. And then we went on to do the dynamic infrared thermography to map the perforators. And Eva took on the clinical studies that we did. So that's really how we got into developing this.
And this dynamic infrared thermography, you call it DIRT. I mean, that's a great name. I also did some digging. It says in your website that you built it in a shed and then patented that. Is that true?
Yeah. So about, I think 10 years ago, I had this idea of projecting onto patients, and in order to get a prototype working, I found myself like with a old school beamer, like with a big ass thing, and I somehow had to mount it above the patient. It was rather heavy, so I had to build like a contraption to get it on the bed and to get like a proof of concept to convince my supervisors, my colleagues, that this is like a good idea to pursue. And that's basically how it started off. And that indeed is when we patented the technology around it. So we got one patent in place and two pending right now.
But can you just really go into a bit more detail? Just what does it look like in real life for people who can't visualize what this is like? Because you have the infrared thermal imaging, like a FLIR camera, don't you? And then you have a device which is almost like a kind of big tablet to project the imaging onto the patient. So how is this all mounted? How does it all work in real life?
I'll take on this question as well. Yeah. So it's either handheld or it's mounted. So, and first of all, it's just a prototype, right? So it's a prototype that I've been working on and improving upon, but still a working prototype. But the essence is that the technology itself, it calibrates itself. So you hold it above the patient and it finds itself in space, basically. So it understands where it is and that calibrates itself back into projecting the patient. So you can hold it in your hand and move it around, and the image that's being projected on the skin on the patient is basically not moving, although you are moving the device itself. And that means it's very portable, and you can hold it in your hand, or you can mount it onto something that's already like hanging from a ceiling or something like that.
Okay. And then the camera, where is that? Is that part of that handheld?
It's all in that fat tablet you described. Yeah.
Right.
So that's where the patent is also involved in.
Great. So how would you can you describe for us the methodology of this study itself then, please, using this technology?
We used DIRT, so dynamic infrared thermography, and that's based on the relationship between tissue temperature and emitted infrared radiation. And by using that infrared camera that we applied in the Anatomy Projector, we can capture this radiation and make color-coded maps on the skin. And on these color-coded maps, warmer areas appear differently from cooler areas, which gives us insight in the blood flow beneath the skin surface. So to conduct this investigation, we made the investigation dynamic, which means that we applied a cold challenge to the area of interest, in this case the abdomen. So we cooled the abdomen for 30 seconds with a refrigerated bag of water from approximately 4 degrees Celsius. We did that for 30 seconds to create uniform starting point. And from there on, the thermal imaging began. And so appearing hotspots on the skin, they appeared as orange-red hotspots. And we marked those hotspots on the skin. And we numbered them in order of appearance. So the first hotspot had number 1, and the 8th hotspot had number 8. And then after 2.5 minutes, the thermal imaging stopped, so the investigation stopped. And then we measured the coordinates of the projected hotspots using a Cartesian coordinate system with the umbilicus as origin to objectify the coordinates of the perforators.
So this is all done in 3 minutes, practically. Is that right? And let me just get this right. So with your augmented reality, you don't need to use any fancy goggles, do you? It's all projected onto the patient. And so you can then mark out with your pen where the hotspots are following that cold challenge. So just to play devil's advocate then, people have been using fluorescent thermography to mark out perforators for a few years now. How is the projection onto the patient when you're going to mark it anyway any more advantageous than what other people have been doing so far?
Yeah, the advantage of projecting directly on the skin is that you don't need to change from a screen next to the patient itself. So you can just concentrate on the patient and concentrate on the appearing hotspots instead of looking back to the screen and forwards to the patient, which can lead to misinterpretation from hotspots. So I think if you project directly on skin, you have less false hotspots.
Are you doing this immediately? Are you doing this in the OR before you start the case, or are you doing this in the clinic and then projecting it when you get to the OR? How does that timing piece work out?
Well, both actually. It's just basically down to logistics. You can do it in the OR. I've done it in the OR. You can have done beforehand. Yeah, it doesn't really matter in that sense. It's portable. So wherever you want it.
Great. So what were the key results then that you found?
We conducted a prospective clinical research from 2021 to 2022, and we included a total of 71 deep flap breast reconstructions performed in 50 women, And we projected a total of 514 dirt hotspots. And of those dirt hotspots, 97.3%, so nearly all of them, could be verified with handheld Doppler within a 1 centimeter radius. I didn't mention that before, but all projected dirt hotspots were, after the marking, were verified with handheld Doppler to see whether there was a Doppler sign or not.
Yeah, I was one of the things that struck me reading it was the correlation between the hotspots and the CTA seemed super strong, but then clinically it seemed a bit less strong, and I just wondered, is that our CTA is not as good as I thought they were either, or what can you just expand on that a little bit, please?
So I think there was also like a mismatch going on, because you have to record the coordinates at the abdomen during your intraoperative surgery, right? So during the surgery, you need to find those coordinates and you need to mark them, you need to note them down, and you use the umbilicus as like as an origin. So there's going to be some changes between after the incision and during your CT scan, basically. And the fact that we actually had Doppler at all of those, like a high number, like 93%, or was 97% Doppler sound at those hotspots. So it was like spot on. There's a video in our paper that you can also review. It's just spot on onto the X, and there was a Doppler sound. So that means there is some blood vessel there. So yeah, of course, CTA is a gold standard in identifying those, and I think that's absolutely true. I mean, CT doesn't like all of a sudden imagine there's a new perforator, right? So it's there, but the fact that I think it's down to the mythology of capturing the data. There's some error going on there, why we didn't find like also a very high number, or all of those blood vessels were superficial and not like the deep perforators that we should, of course, are going to be using in the OR. So I think there's like the two misconceptions that might be going on, or limitations that we should investigate further on to, because we expect a bit higher number to be told between the correlations, but that's why we did it. That's why we report on it, to find out where that's going to be, a problem or not.
One thing I noticed, and I was astonished by this, was that the mean thickness of the subcutaneous layer on the CTA was only 3.3 centimeters. So you must have a very fit and slim population. I mean, even the range was only 1.5 to 4.6. Do you think the thicker the subcutaneous layer, the more inaccurate the scan would be?
Yeah, I think that's a very good insight, and I think so. So the larger the tissue is, the more insulation basically the FEP provides. However, in the more thicker flaps, the blood vessels are also more prudent. So I think there might be a relation there as well. The more fat cells there are, the more blood they need, so the larger the blood vessels will be. So perhaps your hotspots will even be bigger. So I think it's very interesting to look further into that as well. So on one side, yes, insulation should be diminishing the amount of hotspots that will be visible. On the other hand, perhaps there is more blood being supplied to the flap itself because it's larger in volume by itself, which will need more blood anyway. So right now in our research, we didn't really find any correlation that, but it's because indeed the range is very small. We got quite a fit population, so it'll be very interesting to see you get your massive flaps, how they look on thermography.
I saw your mean BMI is 27 and the maximum was 33.8. I mean, I work in South Texas, so 33.8 would be considered. That'd be very nice. Yeah. Oh. But to your point, I think you're right. I think, and we see this in weight loss patients that have body contouring. When you raise that abdominal flap, often the veins and the perforators can appear really massive. And sometimes you do those cases, you think, oh, this makes good deep.
But I guess the distance from the fascia to the skin will be longer, and so your pinpointing of these perforators at the skin level may be very different from what you find intraoperatively.
Mm-hmm.
Yeah, that's very true. That might be going on. The more laterally you go, the more laterally the perforators actually also tend to travel, and more medial. Usually, they're more pointed towards perpendicular to to the umbilicus. Yeah, it's. I think we gonna need to find out. It's more research is needed, right?
Well, you have to send me. You have to let me borrow one, and I can do one. I can repeat it over here.
Well, actually, I'm very happy you brought it up because I wanted to mention that we started a startup actually with this technique. As I mentioned, we got a patent on it. It's called Exolumen nowadays. Exo from outside, lumen as in a blood cavity vessel, as well as light. So there's like a double name in there when you refer to lumen. Anyway, so it's called Exolumen, and we are definitely looking at early adopters who love the idea of projected augmented reality, who believe that you don't need those goggles or anything to get the data that's available to us in terms of sensors, in terms of AI, in terms of whatever, and it's actually going to be projected onto the skin of patients. So yeah, we need those early adopters, and it would be great if they could contact me, because I need those people who are willing to innovate the field. I need those people around me. I need to find like investors, etc., to get this actually into your hands and get to test it out. Because right now we only got a prototype, and it's here at Radboud UMC, so I cannot ship it to you. It's there are some problems in order to get it really out there, but yeah, we are working on it in terms of getting a spin-off company launched.
That's so exciting! To such a great innovation. And what other applications would you use the technology for? I suppose it doesn't have to be a deep flap; could be anywhere else in the body, or anything intraoperatively we could use it for.
Yeah, that's a very interesting question. We also use this technique for other free flaps. So we use it for the anterolateral thigh flap and for the perforator artery perforative flap. Because in the deep flap you can use CTA as preoperative perforated mapping, but in the ALT flap we don't use CTA preoperatively. So then we just compared projecting of dirt hotspots to intraoperative perforators. And for the BEP flap, it's an issue that the BEP flap is dissected in a different way than the CT scan is performed. So that makes translations from CT scan to the intraoperative phase very difficult. So those are two flaps that we use this technique also for, and we also published these in 2 separate articles, and they provide promising results.
So just want to go back to your result a little bit, because you showed that the positive predictive value for the CTA was 74.5%, and also that 97.3% of your hotspots could be verified on Doppler. Now, are these numbers as good as you hope that they'll be, and what level of correlation would you require, do you think, before this is commercially widespread?
I think we are quite satisfied with 97.3% that had an arterial Doppler signal, because we are projecting dirt hotspots. We hope that there's an arterial blood vessel beneath it, and I think I agree we should do future research to see which of those are sacrificial, or if they are like really the deep perforators, where I think as it is a pilot study we can be quite happy with these results. And with positive predicted value compared to the CT scan, I think we can also be quite happy.
Yeah, it is a pilot study after all. So we set out to get like a proper number of deep flaps to at least know a little bit about the technique, if it's going to work or not. And as mentioned before, there definitely are some limitations in how we did our measurements and all that stuff. But all in all, I'm very pleased with 97% of Doppler. I think that's a very good, because some people only use Doppler. Let's keep that in mind. And some people just say, I just Doppler around and then I'll go in. Some people don't do CTA at all. And that means basically that you can replace Doppler with thermal imaging in that sense, because I'm saying it's like near 100%. So yeah, that's quite good, I'd say.
So in your ideal world, you'd do away with Doppler, do away with CTA, and just have this dirt technology.
Well, I'm not sure about doing away with CTA because you don't have the intramuscular trajectory, of course, of DIRT, which might also be of influence to your ways of doing surgery. Also, you're missing out on how thick your flap can be, because we also do like the flap size planning on there as well, as I mentioned earlier, to see how much volume you can get and how large you should do your cut, and do your harvest. And lymph nodes also can be visualized for lymph node transfer during your deep flap in case of lymphedema. So there's definitely way more information available in CTA than there is in thermography. It just shows that there is another tool in your toolbox that you can use in trying to find perforators. I'm not recommending anybody to skip CTA for now. It's a pilot study, and I'm just saying that, it seems as good as Doppler.
Well, we're both very excited about the technology, and maybe even get my hands on one. This is a wonderful spin-off of the podcast. I think this episode is our first episode of 2026. So perhaps I can ask you both, what are you guys most excited about for the new year in your department, and what's happening over there?
Well, I'll start off because you're asking us both. I'm very excited with the launch of Exolumen, which really means it's not going to be shelved on an academic shelf somewhere because, hey, that's another cool thing we did. And I really believe that if you do something cool and people would like to get their hands on it, it's going to be the next step. You can only build like so many prototypes, and after all, you're going to find issues with regulations. So eventually it's going to be CE, MDR, FDA, all of those wordings. They got to be done basically in order to actually get it into the OR. And I'm very excited that we can hopefully start doing that in a company.
That's super exciting. There's so many people now trying to get into that innovation space, and you've kind of gone right from bench to bedside, and can you just tell us a little bit about that journey? How did that come about? What are the challenges, for people who are aspiring to do something like this? Any tips and advice?
Don't be let down. Just keep on going. As I mentioned, I've been working on this for the last 10 years or something like that, and it's you just keep on going, really. People will tell you it's not a great idea. People will tell you all the companies are already doing it and all of that stuff, and just keep believing in your idea. Try to find good people around you who can help you. Try to find enough enjoyment in getting your innovation, because it's going to be tough every now and then, but in the end I think it's going to be all worth it, really, because you're really working forward, and it's easy to do what everybody's doing. It's hard to find something new and believe in it and go for it and be enthusiastic about it. And just keep on going, just keep innovating, just trying to find new stuff. Ask yourself why should we do it like that, and why shouldn't we do it like that, and just keep going, really.
And build your prototype in your shed.
And that helps. It helps to have a shed. It helps to have a shed.
Eva, how about you? What's happening in 2026?
I hope we can make more work of this project with projecting things. So now we use DIRT, and I would be interested to see whether we can use it more intraoperatively to assess perfusion of the flap, or postoperatively to do the flap monitoring on the ward. And it would also be interesting if we can see, if we can assess perfusion areas with thermography. But it can also be interesting if we could assess, for example, depth of burning wounds, if that might be an area of interest for projecting. So I'm very curious, what else we can do. But we will discuss this in the very future. So I'm very curious.
Well, thank you so much, guys. Thank you so much for joining us on the podcast. Happy New Year. And
Here, here.
it's the future of your projects, your company.
Thanks.
Thank you very much for the invitation.
Fantastic. That was an awesome episode. James, what were your main takeaways?
Well, look, I loved it because it's that whole thing about being an innovator. Stefan was talking about how he designed it in his shed. And so this is what we should all be doing in our spare time. Anton, tell us about how this paper might impact your practice, because you're a high volume breast recon guy. What do you think about this?
Yeah, thanks, man. It's no surprise to me that it won the prize for most cited paper because, you know, on the one hand, you know, augmented reality, I think, is really at the forefront of current innovations in plastic surgery. And on the other hand, it's, you know, investigating applicable to one of the largest parts of plastic surgery, which is obviously breast reconstruction. So, you know, I think it's no surprise that it would win a prize for being the most cited paper. And certainly from my perspective, you know, we do a lot of DIEP flaps, as I know a lot of the listeners to this podcast do. And, you know, you really want to do a really safe, but also aesthetic reconstruction. And so anything you can do to map the perforators, to make that part of the procedure go more smoothly, it just, for me, always gives me more time at the end of the case to do the sort of aesthetic titivation that I think I find most satisfying and most important for the patients. So from that perspective, I think it's fantastic, and I'd love to use something like this.
Right. Okay. So one of the things we touched on during our conversation with Stefan and Eva was about the BMIs. You know, the average subcutaneous layer was about 3.3 centimeters. You come across people with much greater layers than that. Do you think that's going to be an issue for you, or do you think it's worth giving it a go and just see how it works out?
Yeah, I mean, living and working in South Texas, I thought I'd misread it when I saw a BMI of 27. I didn't know they started with 2. Yeah, I mean, we have an upper limit of 35, but I know some of my partners will go up to 40 to do a DIEP flap, which, you know, people have published successful outcomes and series. So it may not be inappropriate, but sure, we certainly need to know the technology actually works, because I think that's something we touched on in the conversation, is the depth of penetration of the AR, and to be able to map the perforators, you know, through that sort of extra thickness compared to what they've seen in their healthy Dutch patients. Yeah.
I guess the really exciting thing for me, of course, is that, you know, this is going to be technology that's applicable to all other types of flaps. This is just the beginning, you know, to be trying this on the DIEP flaps.
It's probably even more relevant, actually, isn't it? And I think the DIEP flap's a great way to study it, just because there's a high volume in terms of the sort of the research numbers. But actually, you know, DIEP flaps are pretty common, and people are very confident in how they raise them. But, you know, maybe for the sort of so-called freestyle perforator flaps all around the body, this could be yet another step change. I mean, Professor Way taught us, you know, if you could just find a Dopplerable signal, you could base a free flap on it. But now, you know, you could actually map it out using this technology. So
I think that's the whole world of, the whole world of the super thin, skin only perforator flap and all sorts of things. This might be all applicable to that.
Fantastic stuff. So obviously, if there are any non-microsurgeons listening to this talk, I hope you enjoyed it as much as James and I obviously did.
Great. Well, until next time.
The rest is plastics.